The conference would not be possible without our wonderful sponsors. And we'd like to acknowledge the sponsors now at this time.
So we're going to get started with our discussion. And I just wanted to say that I'm going to try to get all of our questions answered, but we have to understand that we do have limited time. So I'm just going to get started. So our first question is, why do some people shake and others don't? So I'll leave the floor open for any of you guys to answer that.
Yeah, I can answer this question also because otherwise it will take like how many slides, Manda, to
I'll correct all the wrong things he said.
Okay, well, as you know, not every Parkinson's patient has tremor, and this is something very clear to you. It's not clear to a lot of people out there. Everybody thinks that in order to have Parkinson's, you need to have a tremor. And the reason why not every person with Parkinson's shakes is where the pathology is. In some people, pathology is a bit more spread in the brain, and also the areas that are supposed to be there to cause a tremor are gone. And this is called rigid akinetic syndrome, so there's mainly rigidity and slowness, but not tremor, because even the area that are supposed to be needed to manifest a tremor are not there. So from this, you can tell that when we see people with tremor, we think that we're dealing with a relatively benign process because there is less degeneration going on, especially when this is asymmetric, when only one side of the body is initially affected for many years. So if you can pick and choose what type of Parkinson's you should have, you should definitely pick a tremor-dominant Parkinson's manifesting on one side, because this means that the degeneration is not too much. On the other side, if you have more rigid and bradykinetic form, very symmetrical, this is telling you that the degeneration is affecting more areas in the brain, not just one side, two sides, not just the part that causes tremor and slowness, rigidity and slowness, but also the parts causing tremor. And for this reason, you also realize that with disease progression, some people with a lot of tremor before, with disease progression, the tremor might actually reduce with time because of the degeneration spreading towards these neurons I was telling you about. I hope I answered the question.
Perfect. Do you guys have anything to add on?
No, I mean, I think it's as reasonable as one can get with
There's a reason I'm sitting in the middle. I just want to make that really clear.
Okay, next question. So this question is more so for Dr. Jog and Dr. Fasano. So can deep brain stimulation be used for patients with PSP?
No.
Okay, just a plain no. Okay, we'll move on then. Okay, so this one's for all of you guys. Is there a relationship between sleep disturbances and more frequent hallucinations?
Sleep disturbance is exceedingly common in patients with Parkinson's disease, and it's a complicated topic. Mm-hmm. Right? So there's a variety of reasons why sleep can be disturbed. It could simply be from stiffness at night and not being able to feel comfortable. So that could cause sleep disturbance. Just because you have sleep disturbance doesn't mean that you'll have hallucinations. Otherwise, most of us physicians that have been on call for the last 30 years would have hallucinations every day. Yeah, so that's not, no. So there's a reflection of, so evening and nighttime hallucinations and confusion is an indicator of potentially dementia, right? Okay. Whereas drug-induced hallucinations, so somebody is otherwise doing fine, but then when they take, let's say, a dopamine agonist and they get hallucinations, that's a drug-induced side effect. Yeah. Right? The other thing that can happen is sometimes people get an infection. So you've got an, subclinical urinary tract infection, or mild pneumonia or something like this, which is not symptomatic, but then that changes from a third-party way the pharmacology of the brain. So we look for those things. So sleep disturbance specifically, I don't think I say, oh my gosh, there's a sleep problem, you're going to start hallucinating. Okay. I don't think that.
Let me clarify what you just said for people to understand better. No, I'm joking, of course. Well, kind of. No, but I guess from outside, and this is what you just heard, sleep problem means many things. So probably whoever asked these questions had in mind people with so-called vivid dreams and confusions in the middle of the night. The patient wakes up and see things and is maybe still dreaming and kind of awake at the same time. And as you heard, yes, this may be a connection between sleep problem, but this particular type of sleep problems and cognitive problems. The other aspect of this is what happens during the day. There are certain researchers arguing that hallucinations during the day in some people are REM intrusions. REM is the part of the sleep during which we dream, and you might basically be asleep without recognizing to be asleep for a few seconds, and during that few seconds you see something. So this, the overlap can also spread towards the late evening, for instance, during the day, when you can have hallucinations and some sleepiness.
Perfect, thank you. So our next question is for Dr. Fasano. What causes weight gain from the treatment that was in your presentation?
Yeah, very good question. This is something we see particularly with subthalamic procedures, and there are many theories. Actually, we now know the reasons. In the past, the only theory that was put forward is that this is usually because people were perhaps shaking or having dyskinesias or were having rigidity. All of these are muscle activity that burn calories. So you have all of this before, and actually you probably realize that in some cases you may also see weight loss over time because of these problems. And then once you fix these problems, you're eating the same amount, but the body is not needing so many calories anymore, and you put weight. This was the initial description of the explanations of the problem, and that's true. But there are other reasons. One of this is appetite change. So particularly with subthalamic stimulation, some people might be craving sweets, or in general the appetite changes. And more recently, it's been found that also the metabolism and certain hormones are modified by the stimulation, because this target, the subthalamus, is not far from a part of the brain that regulates weight, which is called hypothalamus. So there's an effect also on the hormonal metabolic state of the body. So it's really a multifactorial process.
I just want to make one small comment,
Yeah.
just to give you a perspective, right? So this idea that dyskinesia and tremor causes weight loss, then all of the Good Life fitness centers would just have people shake.
Yeah.
It's not. This is just wrong, you see, because to burn calories from one Tim Hortons muffin, you need to run on a treadmill for 45 minutes, right? One muffin. So weight loss in Parkinson's disease is a metabolic syndrome. It does not have anything to do with you shaking. I mean, that's just illiterate. Yeah.
Thank you. So here's a question that I'm sure all of you guys hear a lot of. Why does it take so long to get a referral to see a neurologist, and do you see it improving in the future?
Well, I
I
mean,
think that's a
a
question for you in particular.
well, it's a complicated answer. I mean, I'll give you a very simple version of it. Is that by the time to get to get somebody to refer, right?
Yeah, just.
Or our waiting time.
It's a very complicated question.
That's what I'm saying. So
Yeah.
the problem with it is that, physicians outside first need to recognize that this is Parkinson's disease, or that there's a referral required,
Yeah.
right? And as you heard from Dr. Fasano, even that simplistic classification is actually very difficult, because for years you might have, and we know that even with clearly defined Parkinson's symptoms, it could be a few years before you even get to that point, right?
Yeah.
And so for all those years, the person has something that is not just, and so for a community, it's hard enough for our fellows to be able to diagnose and treat Parkinson's disease.
Yeah.
For somebody that's a family physician outside, the lookalikes are so many that when it's sure, then it's sure, but when it's not. And so it takes time because you're just not sure.
Yeah.
So shoulder pain is very common in Parkinson's disease, so 40-50% will just present with aching shoulder. Well, who knows that that's Parkinson's?
Yes.
Only when you see reduced arm swing on that side, maybe rigidity, but you can imagine in a busy clinical practice outside. So that's the first reason.
Yeah.
The second reason is that there's very few of us actually that are doing this. I mean, and a community neurologist, right, in all fairness, is seeing migraine, carpal tunnel syndrome, slip discs and C5 root and foot drops and epilepsy and stroke, which is huge, TIA. In the middle of all of that, you've got to see, so, you know, and what I said right at the start, Parkinson's is not it actually gets more and more difficult to treat over time.
Yeah.
So these people are overwhelmed outside. It's simply a volume issue to a large extent. And same thing with us. I mean, in London, basically it's Mary Jenkins who does Parkinson's work and me for the entirety of this Southern Ontario region. Right?
Yeah.
And if I didn't have 6 fellows, my waiting list would be 5 years, I can tell you.
Yeah.
And that's a huge problem.
Perfect.
I'll add some perspective to that. So having been in Canada and now having been in the US, I can say this is not a Canada-only issue. It's not even a Southwest Ontario issue, right? This is an issue across the countries, across North America, perhaps even around the world. Lack of specialty care, that's a huge issue. This is true even if you're looking to get into a rehab professional who actually knows what Parkinson's disease is. So there's a knowledge problem, there's a having enough workforce problem, but there's also your own willingness and acceptance to actually take that next step to ask for help. There's this is a known kind of issue in the Parkinson's community where I think there's something wrong, there's something niggling at me, but I'm just not quite ready yet to take that next step to ask for a referral. So I think it is myriad. It's both bottlenecks in the system, no matter where you are. It's lack of an endpoint in terms of having specialists, but it's also an internal readiness within each person and within each family to be able to do that next step of asking for help.
Thank you.
If I may add something,
Yep.
because this is where medicine meets society and also politics. There are certain countries in the world, like Africa, certain part of Africa, where there are no neurologists, or 1 or 2 neurologists for the whole country, so just to give you perspective. And the other one is gender issues, ethnicity. These are also major, it's not working anymore. There's also major barriers. It's known that, for instance, clinical trials are usually skewed towards white men. Usually female patients are not enrolled, and also Hispanic or other ethnicities are not enrolled. Part of this is also because of the cultural, maybe, lack of drive towards seeking medical help, but it's also the system is a little bit unbiased.
But it's a challenge. People of color would like to see people who look like them,
You're
who
right.
come from their background. And so this is a huge growing issue around the world where people want healthcare providers who look like them, who come from a similar perspective. And the lack of that, the lack of diversity is a known issue within movement disorders, a known issue within the movement disorder society. I don't remember the exact numbers, and perhaps one of you might, from the MDS article that came out, I'm going to say, 5 or 6 years ago, looking at average wait time, is something like 5 years or 6 years, if I remember that data correctly. And there are places in the world where there are no movement disorders neurologists. I think the Movement Disorder Society is trying to bridge those gaps, but it's a long road. It's a really long road.
Thank you, guys. You answered that beautifully. So our next question is for Dr. Roberts. Could a Parkinson's patient who's not a good singer benefit from music or singing therapy?
Sure.
I didn't ask this question.
I know. It's like saying, can a good pianist benefit from? I think, what singing therapy does, and one of the things I'll point out that the music therapy session identified for you is even those vocal warm-up exercises, right? Me, as a speech-language pathologist, I can sit there and say, gosh, I know exactly what those are doing. They're soft onset in terms of making sure that your laryngeal muscles aren't slamming together too tightly, which is a problem when people just go to voice exercises of being loud, but not necessarily doing it smartly, right? Because if you slam your vocal cords together too firmly, you can actually cause damage to them. But the singing exercises that were demonstrated were not that. Using sounds like hallelujah, or starting words with a Y, while working to increase your vocal pitch was just done perfectly, right? So what those exercises do is help to move your larynx up and down. It stretches those muscles, but it does so in a gentle way. So I think even if you're not a singer, provided you're doing it with a voice therapist or a music therapist or someone who knows something about the voice, it can be incredibly beneficial. What it targets is your respiratory muscles or your breathing muscles. It helps to give you more oomph behind your voice and an ability for your voice box to open and close correctly, so there's enough pressure underneath to start the voice. It doesn't help with speech clarity. It may or may not always help with loudness, but it does help with breath support, fatigue, being able to produce sentences on a single breath. So, like all of our behavioral therapies, and Dr. Jog said this, perfectly, they do a lot more than just kind of working on the individual mechanism or system. You go to a music therapy program and you're with others. You're socializing, you're engaging, even if you're doing that online. So there's a mental and a psychological boost to doing those activities as well. We don't have necessarily the rigorous trials in music therapy and voice therapies, but there certainly is no harm, provided you're doing it underneath the guidance of someone who understands the voice, as the instructor did earlier today, right? So if you're not a singer, go for it, but do so with someone who understands the voice and can help you do it in a way that's not harmful.
Thank you. So Dr. Jog, this question's for you. What are the benefits of using Botox in the treatment of Parkinson's, and when do you think a good time to start would be?
Well, it's an excellent question. In fact, there is lots of need for use of botulinum toxin in Parkinson's disease. We talked briefly about tremor. That's a new and emerging thing in the sense that we're resurrecting that. But outside of that, there are numerous other reasons why we could use botulinum toxin. One, for example, is an eye movement problem that patients with PD can have, which is called blepharospasm. There's another word for it which doesn't matter. So sometimes patients with PD and PD-like diseases have problems with excessive eye closure. So we inject, funny things are happening with this thing anyway. So we inject the eyelids with botulinum toxin to help keep the eyelids open. Mm-hmm. Another is drooling. And there's a recent study that was published, not that recent anymore, but within the last year or so. And we've been doing botulinum toxin injections for sialorrhea for many years, since the beginning actually, and injecting the parotid gland and the submandibular gland. We know that very well that swallowing is actually not enough in these patients as compared to excessive drooling, but it doesn't matter. It's a good enough response that I think it's worth considering. And so those people that are having significant sialorrhea, especially nighttime drooling, because posterior drooling, getting the saliva going down the wrong way, that's second. Third is those patients that have toe curling. I mean, there are numerous uses, but we can just summarize, in terms of toe curling, dystonia of the foot, so difficulty walking because of that, using botulinum toxin in the foot muscles, the leg muscles. We do it all the time in PD. Parkinson's patients don't get spastic like post-stroke patients, so it's not spasticity, but it's toe curling. If it's not treated with dopaminergic agents, I find that quite useful as well. And there are some other ones as well outside of that are being investigated. People are looking at injecting it into the stomach area to allow it to empty. One other use, actually, I should say, which is actually mainstream use for us, is injection into the bladder, right? So patients with Parkinson's disease that have excessive urination. Yeah. So we have a big program here actually for intravesicular or intra-bladder injection of botulinum toxin. It really works well. Yeah.
Perfect, thank you. Okay. So this is a question for Dr. Fasano or Dr. Jog. What is the most effective treatment for ignition problems and for freezing of gait in Parkinson's patients?
You're going to say spinal cord stimulation.
Sure, yeah, okay. So, I mean, there are two ways to classify this, and I'll do it very quickly.
Yeah.
Those patients that are experiencing what's called off-freezing, right? So people that are wearing off their medication, you optimize their medication and try to get them to take medicine properly, maybe right times, without food, all those other things, add some extra ones. There are some drugs that, for difficult reasons to explain, may worsen. So sometimes dopamine agonists can worsen. We use other drugs like amantadine sometimes to help. So those patients that are having off-freezing, there are all of these strategies. We did work on something called on-freezing, and those are patients who are optimized with their medication and yet are freezing. right? And so
Yeah.
that tells you that the control problem that is occurring is not the same as the control problem. Just like Dr. Fasano said about tremor versus stiffness, and different. So Parkinson's is not a simple disease like this.
Yeah.
In those cases, the most simple thing to do is use gait aids, right? So it's using canes and laser canes and walkers. So we know very well if somebody uses a device to walk and they're using something like a laser cane, you can improve their gait.
Yeah.
And so simple things, if it's done. What we did was using a technique called spinal cord stimulation, which is a well-accepted therapy for treatment of pain in patients. So we've sort of, used that technique to put electrodes on the spinal cord. Very specialized group of patients. We're still recruiting. We had obviously a downtime in the last year because of the COVID thing. And so initial publications, all very successful in. There's controversy, and the work that Dr. Fasano and his team did in a small group of patients in Toronto, it didn't work, but in our case, it seemed to be working. We now have 5-year data we've published, and there is something there, right? There's a signal there enough for us to consider again, a selected group of patients, this therapy. Freezing of gait is a very difficult thing to treat, and a unique phenotype of Parkinson's.
Yes.
May I add a couple of
Yeah.
things? So the first one is that, as you heard about spinal cord stimulation, that is still experimental. So there's still research going on, and I think part of the reason, in our experience, this wasn't that successful is that we didn't enroll people that were walking. We enrolled only people already in a wheelchair. So maybe they were too advanced to take advantage from this procedure, but it still remains experimental. I think there are two major information that I think you need to be aware of. The first one is that in some cases, medications can trigger freezing of gait. And that's a little bit of a paradox, because the patient goes to the doctor, say, I'm freezing more, and the doctor will simply increase the dose, and the patient will go back and say, I'm freezing even more, and it becomes a vicious circle. And usually when this is the case, the patient feels better in the morning before taking the medication. But the second other source of information, which I think is the most important, is the effect of exercise and rehabilitation, which is sometimes is way superior to any medical interventions, let alone the surgical ones. It's been proven that treadmill walking helps. It's been proven that certain exercise using cueing, visual cueing, also rhythmic stimulation, that also helps. And the interesting thing about it is that the more you walk, the better your memory will be. And this is not just Parkinson's, it applies to everybody. And we don't really understand why, but it looks like walking is good to the body, to your mind, to your soul, and even freezing of gait.
Thank you. Okay, next question. So this one's for all of you guys, and we'll just go down the line. Do you guys know of any clinical trials that are happening in London or the surrounding areas that our audience can participate in?
Sure. I mean, we are doing, by clinical trials, we mean drug intervention studies.
Sure, yeah.
I've not been doing drug intervention studies for quite a long time. And the main reason for that is because other people can do them.
Yeah.
And so we don't currently have in London recruitment for a pharma company funded clinical trial. But we're doing lots of clinical work, not clinical work, but science in my lab. So this transcranial stimulation for off periods and dyskinesia, we're actively recruiting. We've got this very large study that I was saying from Norway called Stratpark that we're actively recruiting. We've got some really one-of-a-kind imaging techniques that we're the only ones in the world doing this kind of very micron level microvascular imaging in early, late Parkinson's. The idea is to enroll 2,000 patients, so it's a very big. So my lab is a sort of a bench lab that does this. We are recruiting for the spinal cord stimulation study, but again, it's not a pharma company funded study. It's in our lab.
That's great, thank you. And Dr. Roberts?
Thanks. So from a behavioral trials perspective, in terms of speech therapies or cognitive therapies, there's not necessarily anything really active right now in Southwest Ontario. But there are a lot of these studies, as in the ones I talked about in terms of the speech biomarker work that we do in our lab, that you can participate in fully virtually. So I think it's important, especially now, because so many science programs have gone to this partially virtual data collection, to think about studies that are local, but also studies you can participate at an international level. Certainly everyone needs research, people involved in research. I will say probably the study that's most relevant to folks here is the one that we're doing with Dr. Lang's group, where we're looking at doing a virtual levodopa challenge and trying to get a handle on what are the, kind of almost minute by minute on and off cycles around medications, both in the home, as well as comparing those to kind of a gold standard levodopa challenge test in the clinic. And part of the reason why Dr. Lang and Bill McElroy, Karen Van Uddingham, and myself are kind of coordinating on this study through the Hands Ontario or the OBI funded initiative is to be able to have the opportunity to take that long all-day process of doing a levodopa challenge test in the clinic and to be able to move that to the home and to extend that beyond a one-day trial into 6 or 7 days of kind of continuous recording. So that's a study that is definitely coming up and will be active within the next 8 to 12 weeks or so, and if you're interested, let me know.
Well, I can talk about Toronto, which is still Ontario, so in case you're interested. As I said before, we're recruiting right now for a stem cell trial. The company's name is Blue Rock. It's a technology that was developed actually by University of Toronto, but then the company brought it to New York. So the company is New York and Boston, and these are the sites for this trial. It's a phase 1. Phase 1 means it's the first time it's done in humans, which obviously carries some risks, and this will be a safety trial to, first of all, figure out if it's safe. The second trial that you might be interested in hearing is so-called ADAPT, which is using a new device, a new implantable device for deep brain stimulation that is able to record the brain activity. And so this will make us use a different type of stimulation called adaptive stimulation or closed loop stimulation, which means that the stimulator won't be on all the time, but it will be on and off at different strengths depending on what's happening in the brain. So the system will read and interpret what's happening in the brain and adjust the stimulation in an automatic fashion. And we're recruiting for this one already. We've done 3-4 cases so far. And then there is a variety of different pharma trials, particularly with the intent of being disease modifiers. But these are a little difficult to be enrolled in, and this is one of the problems that is linked to the long wait time. Because what happens sometimes is that when the wait time is too long, the family doctor says, well, I think you have Parkinson's, it's going to take forever for you to be seen by a tertiary center, so let's start levodopa. And for many of these trials, people need to be drug naive. So they should not have tried any medications, and they should not be expected to progress in a fast manner, meaning that they will need something. Obviously, you don't want to do that because ethically you can't enroll a person and you say, no, you should not be treated with anything because we need to see whether this medication changes your disease. So this means that we are looking for very early Parkinson's patients not treated to try these medications that are supposed to change the progression, like antibodies for synuclein, or some of the drugs that you heard before working on GBA or LRRK2 inhibitors. So there are different drugs, but it's extremely difficult to enroll them. And what happens very often is that we need to close the trial because we don't have enough patients, or contract and ethics takes forever. So it's quite painful to do clinical trials, as you can imagine, I guess.
Thank you. So this next question, I think Dr. Jog will be able to answer. I know you were talking about transcranial pulse stimulation in your presentation. So could you speak on how it could ease dementia symptoms in Parkinson's patients?
Yeah, so I mean, the idea behind any of these non-invasive stimulation techniques is to assume that, and it's not an assumption, it's correct, is that in addition to having specific things like dopamine loss or loss of another chemical in the brain, that this changes how the entirety of the network functions. Well, is it possible for us, without having to go into the brain and be invasive, to record these changes? And these are not new things. People have looked at recording EEG, doing fMRI, and I'm a huge, I hate that technique. But these kinds of FNAIRs, you name it. But there are a variety of ways to try understanding network. So we have a specific expertise in looking at doing new forms of mathematics on network connections within the brain with electrical recordings as compared to imaging, which I don't believe is specific enough. And so using the concept that this is a network of neurons, billions of them connected, maybe we can record this dysfunction, and based on the recording of this dysfunction, can we deliver through the skull energy that's going to get in there? Lots of I'm probably the biggest skeptic of this in my own lab. But at the same time, there is a literature out there on this. And so one of the things that we're pursuing in the lab is to be able to see whether we can at least change the network. That's not that difficult to show. Whether it changes the person's function, that's much harder to show. So it's in the beginnings. There are many different non-invasive techniques, including direct current stimulation, alternating current stimulation. We've developed a technique that is based on something called pulsed current stimulation. I won't go into the details of the technology that is developed. And it's a homegrown device that we've built based on the assumption that different networks may respond to different ways of stimulation. So this particular device allows multimodal stimulation. So it's getting, 1 gram of sugar along with 2 grams, along with 5 grams, along with 15 grams, all interlaced in a particular way. And the idea is that you can do this over there. Let's see what happens. I mean, this is I wouldn't call it cutting edge, because that's assuming that this is, from a device perspective, very trivial. But whether it'll actually allow us to do anything in the brain, we'll have to see.
Yes.
So I do want to address, people have looked at transcranial magnetic stimulation for speech and voice issues and Parkinson's disease, and we just wrote a recent review on this. At the end of the day, at least for that particular technique, and I think this is not to say that all kind of neurostimulation approaches don't work. So I'm not saying that, but there, as Dr. Jog said, there are different ways of doing the stimulation. There are different, not just different mechanisms for doing it, but actual different ways of doing it in terms of the patterns of stimulation and where you stimulate. From the speech side, though, that literature has been relatively disappointing. So when those studies are well controlled, meaning that there's a controlled sham and people think that they're getting stimulation when they're not getting stimulation, in general, on speech and voice, that hasn't necessarily been as effective. Both groups will generally report that they feel like they're doing more in their daily life, so their communication participation is improved, but actual changes in speech and voice are not there. So it does seem to be, at least at this stage, for what's been tried in the speech realm with TMS and TCDS, that it's largely not necessarily effective for those symptoms, but different mechanisms of stimulation may very well work differently for sure.
Thank you. So the next couple of questions are more about medicinal treatments. So we'll get started on that. Sorry if I butcher this name, is Neurians a new medication for off time available? I don't know if I'm saying it wrong. It's Nourianz. Or if you guys know.
It's the one approved in the States. I think it's amantadine.
Yeah, maybe the longer acting amantadine?
Yeah, I think it's the, well, it's not available in Canada, as you can tell, because we don't even know the name. But it might be the extended form of amantadine, if not mistaken, or it's tradifilin. Anyways, which we can talk about both. There is a long-acting amantadine formulation in the States, and doesn't add anything to what you have here. The reason why they did it is because it's a different patent, and this means that the company can make money for longer. Each time there is a new patent, you have 10 years, and that company can be the only one selling that drug. So every once in a while, you see little changes in the molecule, and they will claim that this is a different drug, but it's actually the same thing that just lasts longer. The other one is it might be that is isdifilin, which is an antagonist of the receptor. Yeah, that one. Okay, it's the one I was thinking. This is a receptor, it's an antagonist of the receptor for certain amines in the brain, adenosine in particular. And this is basically what a coffee does to you. So when you drink a coffee, you have a certain effect. Actually, you move more, you speak faster, you burn more calories. And as you probably know, there is also data showing that big coffee drinkers have a reduced risk to develop Parkinson's, Alzheimer's, and there's a lot of discussion whether this is the case or not, but from a symptomatic standpoint, we know that caffeine helps. And this is why a number of drugs have been developed working on the same mechanism. We don't have it in Canada, but I can tell you that you're not missing much, and I can give you a reason why. This drug has been available in Japan for, I think, already 10 years ago or more, 15 years ago, and it took so long to be approved. When you see such a thing, it means that you don't really have a strong signal there, but in theory, yes, has the potential to improve motor fluctuations.
Thank you. So our next question is about nasal sprays. Is that a faster way to get medication to the brain?
Yeah, I mean, there was a study done a few years ago,
Levodopa.
same kind of a thing in terms of puffer, right? Not to be able to get levodopa. I think it's available in the U.S.
It's called Imbrilia. Yes,
Yeah.
there is
So we don't have it here, but.
Those are rescue medications.
Yes.
Yeah.
And the idea behind it is that, it takes so much longer for levodopa to get down to the jejunum, where it's absorbed down here, right? So, and there are lots of ways it can get stuck. Not taking enough water is one way.
Yeah.
Delayed gastric emptying is another. Food content in the stomach is another, et cetera. So you don't have any of that in the lungs. So you take a puffer, it goes right into the lungs, right? And so it's, but the difference is that levodopa does not have any carbidopa. So you need to be on levodopa, carbidopa by mouth to be able to take that. It's kind of like apomorphine injection.
Yeah.
It's add-on to the treatment.
Yes, that makes
Just to
sense.
expand a little bit on that, because for longest time, the only rescue medication you had here in Canada was crushing the tablet of levocarb and have it with carbonated water. When I saw this, when I came here, I was shocked, because in many other countries, there are a lot of other formulations, including effervescent tablets that you put in water and then becomes liquid levodopa. And this is because one of your biggest enemies is your stomach. Stomach keeps the medication in there, and it doesn't get pushed away in the intestine where levodopa is absorbed. So you need to find additional routes to provide levodopa to your brain. Yes, liquid levodopa clearly goes faster, but still not very, very effective. And now you have two new ways that were mentioned before by Dr. Jog. One is subcutaneous apomorphine, the other one is sublingual apomorphine. And as you said, Amanda, I used particularly the subcutaneous one for many years. And subcutaneous is certainly faster because it's a needle, it's faster. The sublingual one is a little slower to kick in, talking about half an hour. The first one will be 15 minutes. So they're a little different, but certainly you have now new rescue medications. What's available in the US is this puffer that you just heard of, and the nasal one, going back to the question, is still experimental, but the mechanism would be the same thing. There's a reason why addicts, like cocaine addicts, they take cocaine from the nose because it bypasses everything and goes straight to the brain. Same thing will apply here to levodopa. Levodopa, not cocaine, okay, in case you want to.
So I'm going to take panelist prerogative here and maybe ask an extended question. As physicians, what do you need your patients to say to you, and how do they need to communicate it so that you know how to balance what is the regular medicine plus a rescue medicine need, right? So how can patients communicate that to you?
Well, the severity of off is a very nebulous thing. And the problem with it is that, we're really largely only in Parkinson's disease, even today, concentrating on the motor off. So what you don't want to have somebody do is be in the mall, as I was saying, and be stuck. Sure, you can have an anxiety reaction as an off. You can have so many, and so those become very nebulous to demonstrate as to where you want to intervene. So I think Alfonso will agree that, we largely still concentrate on the motor state of the patient. Now that's easier to measure because I do this all the time in clinic now, just have if they complain, so what is your, either we do an off on if that's still something that one wants to do, or have the patient wear off in front of you in the waiting room and say, okay, this is pretty bad off. So your observation. If you don't get the history very clearly. that remains an issue as to what the degree of off and how you judge it to intervene with rescue. These medicines are tough, right? I mean, they cause a lot of nausea. You still have to inject, and I mean, they're not, the sublingual one is easier, and so I think probably you'll have better uptake, probably a little more liberal with that one than the injections. The other medicines can also be used. You can adjust the levodopa, I mean, instead of adding something new, or you can add a dopamine agonist if it's allowed at that stage and it's permitted. So,
Yes, I agree with what you said. Of course, I have 3 more things to add to this. One thing is the severity of the OFF. In particular cases, it's actually easy to realize when the OFF is really severe. For instance, pain, cramps, painful cramps. Even when they're very short, they can be extremely disabling. For instance, early in the morning when you wake up. So those will be, for me, episodes that might need a rescue therapy. The other one is unpredictable fluctuations. I don't know if you are familiar with terms like delayed on or no on or dose failures. There are certain situations, particularly in people with a lot of constipations and slow gastric emptying, and you know why, that the medication is taken and nothing happens. And this can be very unpredictable, usually correlating with how much constipation there is at the same time. Those are reasons to bypass the gastric system and use these drugs. Last but not least, the emotional impact of being off. Some people decide not to go to the movie theater or to that restaurant, whatever, because what if I have a freezing episode? Maybe it happens once a week. It's not common, but what if it happens while I'm there? I don't want to embarrass my partner, or I don't want my friends to see me stuck there, and that's why I don't want to go. So having something with you that in case of this situation you might use to as a rescue strategy gives you that peace of mind, that confidence, and you do more, even if it doesn't happen. The same thing happens to people with anxiety. They always go around with an anti-anxiety medication with them. They don't use it, but simply because they have it, they're fine and they can do it.
Thank you. So this next question, is there any new research regarding medical marijuana in helping Parkinson's symptoms like tremors, or no?
well, Dr. Fasano uses it, so I'll let him
Yeah, of course.
explain.
I used it this morning before I came. Okay, so this is actually one of those things that tells you that what's the impact of media, and particularly in this case, YouTube. There was a video at some point of a man, probably you saw it, that smoked some marijuana, and he looked like he was another person right after. Now, keep in mind that in Canada, marijuana is legal, so you can go and buy it. If you want to try it. But I'll tell you, not much is going to happen. And if you want to do it, don't take THC. Use mainly CBD, which is the one that calms you down, because THC might cause psychosis, might cause hallucinations. So don't experiment, but in case you want to try, I'm telling you, you can do it, and you won't see much. So these drugs calm you down. Yes, it might help sleep, it might help pain, it might help tremor, because as you know, when you're relaxed, you shake less. But is this a treatment? I don't think so. And it's not just my personal opinion. The one thing that nobody talks about is that there have been studies. It's been at least 15 years that marijuana has been tried. And these studies have shown with rigorous methods that it doesn't really do much. It might do something for pain, sleep, that's it. Anxiety, maybe, no more than this.
One last little comment is that you have to remember it's still a drug, right? It's not something, coffee is a drug, as you heard very nicely from Dr. Fasano. It's an A2A receptor agonist. I mean, it's an adenosine receptor modulator. So everything that you put in your body is quote unquote, a chemical. Yeah. So make sure you respect that.
Thank you. Yep.
We have time for one more question.
One more, okay. Okay, so these are all just like super specific drug ones. So do you guys know about mannitol?
Yeah, it doesn't work. Yeah, it's
Doesn't
one
work.
of those things that
Okay.
you see on the internet. Yeah.
Probiotic, VSL3.
Probiotic work for constipation. You can try that.
Okay, and then we have cerebral dopamine neurotrodotic factor.
Growth factors I talked about very briefly, and I think, again, very experimental.
Experimental, yes.
Okay, and last one is Genesis medicine, a brain-blood barrier stimulation approach.
Well, that's, I think, what, I don't know if you
I
talked about.
mentioned, I mentioned that before. So focused ultrasound can be used to open the blood-brain barrier. And this can be used to bring molecules. For instance, a term that you heard before from Dr. Jog is GBA. There's a particular enzyme that misses in people with a mutation of GBA called GCase. This is an enzyme already available that people inject to treat Gaucher disease, but it doesn't work in the brain because it doesn't cross the BBB. And now there is a study going on, opening the blood-brain barrier, injecting at the same time this enzyme so that they can cross the barrier and get into the brain in people that are missing one of the copies. So there's less GCase activity in their brain. And this is a very interesting approach. I'm actually quite confident it's going to help particularly people with GBA mutation, potentially also people without the GBA mutation as seen in animal models.
Okay, thank you guys. We got through all the questions. I
Nice.
think you answered them beautifully.
Especially Dr. Jog.
Oh, it is, okay.
Thank you.